Thank you everybody for coming. Like Jeff said, my name is Madison. I work with Options by Town. We're a housing nonprofit located in Ottawa. I'm a housing-based case manager on the Housing First team. So before I begin, I'm just going to do a land acknowledgement for Ottawa. Options by Town acknowledges that the land upon which we work and live is traditional, unceded, unsurrendered territory of the Algonquin Anishinaabe Nation. We recognize that colonization has directly resulted in homelessness and displacement from land, culture, and communities. All right, so we're just going to get into my objectives for this presentation. I aim to show the correlation between clients participating in peer-led programming and their success within the Housing First model. At Options by Town, peer support is really at the forefront of our program and what we do on our team. Right now, we have 2 peer support workers on our team. They work in partnership with a housing-based case manager like myself. During the presentation, I will highlight the different initiatives that promote community engagement. I'll also explain our team's different initiatives and strategies that support community engagement. I'll also explain our team's action plan for implementing these strategies, as well as show the positive impact for community programming, and also provide some really good concrete examples as what our team used to implement these, and hopefully you can take home with you. All right, so some context as to what sparked my idea for this presentation and why I thought it might be really useful for everyone here. So every year, our clients do something what's called an RBA survey. It stands for Results-Based Accountability. It's really a chance for our clients to give us feedback of what we're doing well, what's not working for us, what support they would like, what resources. And we take that back and implement it into our programming on an organizational level and strategic planning. So the next few slides, I'm just going to have some examples of the questioning. So the first question here is, what else? Can you hear me when I step away from the microphone? Yeah. The first question is, what else would you like to support? What else would you like support with? So the 3 main ones there. The first one is socialization, I think, which really shows the need for our clients that they really need that socialization. And the other ones kind of compound that too with employment and computer skills. The graph below shows in which of the following areas of your life do you feel Options by Town could help you recover from the COVID-19 pandemic. And with a staggering 69%, it was access to community resources. And our team really noticed, even before the survey was handed out, we really noticed a large gap in accessing community resources, especially with COVID. A lot of our drop-ins were closed, a lot of resource centers were closed, so our clients were really left alone in their apartments. And it's really highlighted on this slide right here. Only 23% of our clients found that we helped them with socialization and social programming. Compared to a 77% of maintaining housing and avoiding evictions, which is a Housing First team. That's great that we're helping so many people get housed and avoid evictions. But it really highlights that, that gap in resources for our clients. So we really took that into account for the last couple months of what we wanted to work upon. So it's really nothing new in Housing First, integrating that community perspective. With the research that's been done time and time again, we know that it works, and it's so vital for our folks to maintain housing. So we really took that into account when we received our RBA survey and what we were going to work on in the following months. So now that we know that, how are we going to do it? What's our action plan? So we had 3 main objectives in what we were going to work on. The first one with engage with our community partners. We're really lucky in Ottawa. We have so many different resources. We're a really rich resource community. The second one was incorporate community integration into support plans. And the last one was refer clients to support programs. As I mentioned, we have 2 peer support workers on our team, and they work in tandem with a housing-based case manager. So the first one I'm going to discuss is our peer support program. Like I said, peer support is really at the forefront of our team. They play a really crucial role in helping the Housing First team to provide treatment and support services in a manner that is grounded in recovery principles. When working with individuals who are chronically homeless, it's often the peer workers who can best relate to the client and their experience. By demonstrating this understanding to the client, it's able to earn their trust to a profound degree. And I can really emphasize that. I know I've worked with so many clients where when I met them, it was hard to build that initial trust. And we brought a peer worker in and they were really able to open up with them. And in turn that they were able to trust me and build that relationship with me. So it's really incredible to see. They also just provide such practical support with our clients. They do things like go find grocery stores, go find laundromats. Once we get someone housed, it's really important for our peers to get involved and show them around in their community. We also, like I said here, we do a lot of peers facilitated programs in our team. We've had stuff like fishing trips, art classes. I know right now our peers are working on a Christmas activity. We also had things that are grounded in recovery principles, so taking clients to AA meetings. And this has been really successful on our team because we found once we bring the client to the AA meeting, they're more likely to go back. They meet people who have similar lived experience. They meet people around them and they go back. They get that confidence back and they want to keep going. Like I said, community outings, going on fishing trips, doing art things, whatever that client's interested in, we really try to get a peer involved and get them out into the community. Because I know for myself, when you're going somewhere for the first time, it can be scary. Like you don't have the confidence. So having a peer go with you, someone with that lived experience, it really boosts your confidence. And the peers are also able to provide that one-on-one practical support. They're able to meet with someone, whether it's in their house, whether it's in the community on a weekly basis, a bi-weekly basis, and either talk about their recovery, what they're going through, really be able to share their experience with someone who understands them and has been through similar things. The next thing that we have worked on is building a better relationship with our community partners. Like I said, in Ottawa, we're a really rich resource city. We're really lucky. So we did 3 things to really highlight this. We started putting together a resource package for our clients when they move in. A lot of our clients move into new areas they've never been before. So they might be unfamiliar with, what the doctor's office closest to them, the grocery store, the food bank, another really important thing. So we put together a package when a client moves in so we can give that to them so they're aware of all the resources in their community. We also started prioritizing inviting at least one community partner to a staff meeting so they can come in, we can learn about different initiatives or different resources that we might not be familiar with, and we can take that back and show our clients and help them become more supported. We have also added a section to our weekly meetings to share any new resources we've come across. Usually housing-based case managers are in the community, so we're out a lot, we're seeing new resources, things that we might have not known, so we can bring that back to the rest of the team and share that amongst each other, which is really neat. And the other one, there we go, is community reintegration. This is quite new for our team. So we're starting something called community mapping. It's sometimes called access mapping. It's all about involving clients in identifying the assets of their neighborhood and creating a picture of what it could look like. This is a pretty new initiative, like I said. Our peer workers will be leading this program. Once a client moves into their new home, our peer workers will help them to explore their new community and connect them to resources they're interested in. This could look like peers and the clients walking around their new neighborhood, identifying community centers, food banks, local parks, local pharmacies, whatever in the area that they can help them move in and stay securely housed. We're also participating in a social prescribing pilot project with Ottawa U. I wish Tim was here because he could probably talk better about this than I can because he's spearheading this. For all of you who don't know, social prescribing is a holistic approach to healthcare that brings together the social and medical models of health and wellness. Social prescribing is a practical tool for addressing the social determinants of health through supported referrals to community service. This global initiative aims to meet the gap of unserved populations and better link them to health and social care organizations. So this can look like, referring people to, instead of a doctor, maybe go to the park or maybe meet up with some friends and, do an art class. I know we've just finished the focus group stage, and I think they're launching this later in December. And I know a lot of our clients are really excited about this, especially post-COVID, where a lot of our clients have felt quite socially isolated and haven't had the opportunity to participate in their community. I think it's going to be really beneficial for a lot of people, and really ensure that people are successfully housed for a long period of time. In closing, there's a direct correlation between community reintegration and long-term success in housing. This can be achieved in other Housing First programs by, one, engaging with community partners, incorporating community integration into support plans, and referring clients to peer support workers. Thank you.
Oh, thank you, Madison. The next presentation is by Ada Aga, and Ada is a PhD student in the University of Ottawa's Community Psychology program. Her presentation today is titled Housing Stability and Social Capital, a mixed method analysis of the relationship between housing stability, psychological integration, and social capital among individuals with histories of homelessness. So welcome, Aga.
Okay, let's get this up here. Okay, I'm a little short, so hopefully you guys can see me. Okay. I want to thank Madison for her presentation, because I feel like you are explaining the how to do, and I'm going to try to explain the why we should kind of do what the importance of community integration and how it relates to social capital. So I feel like I'm preaching to the choir here, but we should all be familiar with the social determinants of health. And as Madison mentioned it, one of the ways we've been talking a lot about how to end homelessness, but really it's about addressing these social determinants of homelessness that we really find our way out. So Housing First, in a way, is trying to address these social determinants not only by providing housing, but also with the goal of social and community integration. So I think it's about opportunities to participate, to engage in meaningful activities. And a lot of people who, once they become housed, they become socially isolated, and that can impact their housing stability. So it's really important that that piece of Housing First, of getting people back into their communities, is really kind of fostered. And so there has been some research on community integration among people within Housing First programs, but it's kind of a little bit of a mixed bag. Some of them show pretty good outcomes. Others show that many still face barriers. When it comes to the topic of social capital, which I'll define, there's not that much research among the relationship between social capital and homelessness. It seems like something that would be obvious, but a lot of the research is qualitative. Very few quantitative studies have been really done on this topic. So the objective of my research is to explore this relationship between housing stability, social capital, and psychological integration for people who have experienced homelessness. So definitions. I think I'm just going to wing it and ignore my notes. Housing stability, it's usually defined in the work that we've done, it's always defined as the percentage of time or how number of days people stay housed versus being homeless. But it really is more than that. It's about people's opportunity to kind of recover, access health, and have improve their quality of life. And so what is social support and what is psychological integration, and how does that relate to social capital? Because a lot of the time these terms are used interchangeably. So social support, simplified, is the informal or formal sources of support that provide emotional and instrumental. So this could just be resources and tangible objects like housing, like food security, but it could also be having people to talk to, having people to open up to. Psychological integration is a component of community integration that has actually been widely studied in Housing First research, and it's just having a sense of belonging and membership to the communities that you reside in and the neighborhoods that you live in. And so what is social capital? So social capital has many definitions. It's a pretty broad topic, but one of the most popular pundits of social capital was Robert Putnam in his famous book, Bowling Alone. And he defined social capital generally as the value of social networks, the norms of reciprocity and mutual trust among individuals and just generally the greatest society. So it includes the groups you belong to, social connections, personal relationships, and so on. So really the benefits of social networks. And this is just a famous quote that he has in his relationship to, he really is the one who brought social capital as a public health topic. And according to the World Health Organization, social capital is considered as a social determinant of health. And his book, Bowling Alone, really talked about how the more social capital people are engage in, the less likely they are to suffer from health problems. Putnam also talks about different types of social capital. So he famously coined the bonding and bridging social capital. So bonding would be these trusting, tight-knit relationships between people who are, family members, friends, people that you identify with, you sense that you are part of a group. Where bridging is more informal relationships like acquaintances, people within your greater community or neighborhood that you don't necessarily have that deep, close tie with. And they can differ by age or by ethnicity or social identity or even social class, but just kind of these mutual trusting relationships within, in Canada, the taking your cart after you buy groceries and putting it away, like these kinds of little things. And then linking social capital was extended. Someone named Woolnock, sorry, I don't remember how to pronounce it, but he coined linking social capital as an extension of bridging social capital. And this is generally trust in formal institutions and people or in institutions of authority. So government organizations, the police, courts, just generalized social institutions and the level of trust that people and citizens have. There's a lot of talk in social capital research about like voting behaviors, and that's an indication of social trust. I don't really get into that, but I do recommend reading Bowling Alone. It's a very, very famous book. It's a bit dense. I'm still getting through it myself, but it is a really good read, and it's interesting to kind of see how it might have changed in today's society because it was written over 20 years ago. And just to kind of visualize how social support, community integration, and social capital can relate to each other using an ecological perspective. One is at an individual level, one at a community, and then social capital kind of translates to this general societal trust, generalized trust in general. The idea is that the better relationships you have on the personal level, the more that translate into just positive relationships and views of people as a whole and the communities and countries that you even live in. So my first study is a quantitative study, and it's looking at how social support and community integration can be mediators to the relationship between housing stability and social capital. So the research questions are just essentially, is greater housing stability associated with greater social support, with greater psychological integration, with greater social capital, and do psychological integration and social support mediate this relationship? So just to visualize the model, this is kind of what it looks like. These are just boring mediation models. It's not as complicated as it seems, I learned. So the data from this study comes from the Health and Housing in Transition study. So this was a study that took place between 2009 and 2014 in 3 cities in Canada, in Toronto, Ottawa, and Vancouver. And essentially, we followed about 200 homeless and 200 vulnerably housed individuals from each city over a 4-year period. And we interviewed them once a year. And so this kind of just the timeline. It was not exactly once a year, but we did have a pretty good retention rate, and we were able to maintain about close to 80% of our population from baseline to the last year. And so how housing stability is measured. So I mentioned earlier, often housing stability is measured by the percentage or the number of days people stay in housing, and that is how we did measure it in this study. So at every interview with participants, we had an extensive, we even used a map, and we would ask them to tell us everywhere that they were living up until the date of the last interview. We used that to create a timeline map of their housing trajectories. And then we were able to kind of code for every day in the study, whether they were homeless or housed or in an institution. And then from that day-by-day database that we created, I was able to just calculate the percentage of time people were housed over the 4-year period. And then social capital was measured based on an adapted version of the World's Values Survey by Algar and his co-authors. And it just kind of measures trust, bonding and bridging capital, so the level of trust in people that you know personally, as well as people from other religions and nationalities or people that you meet for first time. And then the linking social capital was asking about the level of confidence individuals had in the police, courts, and governments. And linking social capital has never been explored amongst homeless populations, which is kind of crazy because it would be something that impacts their lives so much more, experiences with social systems, police and courts, compared to the general population. So this is the first time that that's actually being explored. So boring tables, but I worked really hard on them, so now you guys have to look at them as well. So these just show the path coefficients of the trust, which is bonding, bridging combined, and linking. And I point this out because these were the control variables, but there's some interesting findings that came out here. One particularly was that people who identified within the vulnerably housed population, people who identified as First Nations and Indigenous had lower levels of both trust and linking social capital, which is a super important finding. You know, we've been talking about this thematically throughout the conference. So this is just tangible kind of evidence that they really do have lower trust in government organizations, and they are lacking in the ability to, you know, foster bonding and bridging social capital. The other finding in these control variables that I included was that greater levels of drug use was associated with lower levels of linking social capital. And here are also my very pretty diagrams that I also worked hard on, so now everybody has to look at them. But what this really tells us is the relationships between these variables. And so the ones with lots of dots show significant relationships. And really, so there are this, in the mediation model, which I'll show in the next slide, the relationship between all of these variables don't necessarily need to be significant for the overall model to be significant, but we are seeing that housing stability is significantly associated with greater social support and greater psychological integration, and that social support and psychological integration are associated with trust and linking, but that between housing stability and the two types of social capital, those relationships are not significant. Which shows that they are mediators. So that means that the total kind of indirect effects, so social support and psychological integration working together do mediate and do influence the relationship between housing stability and social capital. So that suggests that greater social support and greater psychological integration can foster ultimately social and generalized trust for people who have experienced homelessness and housing instability. So my second study was a qualitative study. So the idea was to kind of provide a little bit more insight into the relationships between these variables using the framework, similar framework. So the research questions here was kind of looking at if there's differences between people who have lower and higher housing stability, and in their narratives in the qualitative interviews that we did, how do they talk about their relationships with their friends, families, neighbors, others that they socially interact with? How do they talk about the neighborhoods and the communities that they live in? And how do they talk about their experiences with social services, government organizations, healthcare providers, police, courts, and other and so forth. So I'm not going to spend too much time. At the end of the fourth follow-up study, we did qualitative interviews with a subsample of participants. And from that greater subsample, I pulled about 15 people with low housing stability and 15 people with high housing stability. And then I conducted thematic analysis based on my research questions to kind of see if there is a difference between the two groups. So here are the results of the thematic analysis. So I actually love qualitative research because it just kind of puts everything into place when big numbers sometimes just don't catch the full experience. So in terms of things that were similar and for the bonding and bridging level and their positive and negative descriptions of people they know and people they interact with. So both groups described friends and families and landlords actually as a source of both emotional and instrumental support. They talked about how it was important to treat people within their communities with respect. The concept of the golden rule came up several times across interviews. But there was also many who talked about keeping to themselves. It was often related to drug use, but not always, but wanting to stay away from people or be alone. And it was different than, it was more self-isolation than social isolation. They were choosing to isolate. And there was many who just outright expressed a lack of trust in other people with statements I don't trust anybody or things like that. In terms of some differences, so people who were in the low housing stability group described the negative impacts of drug use or talked about the negative impact of drug use a little bit more, whether it was personal use or within their social networks. They also talked about interpersonal conflict with others, whether it was family members, neighbors, partners, or within relationships. And there was also some themes about negative views of other people who were homeless, which was interesting, or trying to set themselves as, no, I'm different from the others who are from other people who are in shelters or who are living on the street. One quote that came through was, I don't really trust low-class people anymore. I'm dying being in this shelter. It's killing me. In terms of community integration and positive negative descriptions of the neighborhoods and communities that they were living in. So negative descriptions were often related to safety issues like drug use and prostitution in the neighborhood. But several participants in both groups just talked about how it's so important to get along with your neighbors. And both groups also described housing as a place to socialize. So a lot of people mentioned being able to have their family members over, being able to have friends over, or even their children to come visit them. That was a pretty big theme to come through. So housing is a place where you are making connections with other people. In terms of differences, the high housing stability group talked a little bit more about housing being a safe place for them to recover, while the low housing stability group kind of mentioned lack of safety or concerns of losing their housing. And it wasn't necessarily within the housing that they were living in, but just kind of that history of knowing that you've lost your housing before, and that kind of being the sense of stress, of worry that you might lose it again. The quote says, it makes me afraid because I'm so afraid that someone's going to come in and say, okay, you have to leave. And then in terms of the linking social capital, which I think, again, is so important for this community and this group of people. So both groups described receiving social support and resources from social workers, shelter staff, family physicians. Many, as Madison kind of pointed out, spoke of a specific service provider, whether it was a case manager, an outreach worker, a social worker, that had a huge positive impact on them. Phrases like this, she saved my life, like things like that. So just the importance of that relationship with the workers really came through. And then both groups described a difficulty accessing healthcare in general and barriers to accessing healthcare, and several comments of a general distrust of doctors, not listening to them, not taking their diagnoses seriously, having to go to different doctors to kind of get the same experience. In terms of some differences, participants with low housing stability were more often mentioning that they had been incarcerated in their interview, and they also described negative experiences with police and courts, so police violence, just generally being arrested, having a lawyer that didn't, that wasn't helpful in their court cases, and so on. And so a highlighted quote was, "I don't care if you're a cop, if you're a doctor, if you're a lawyer, who the F you are, I do not trust you." So in general, how this ties together, and again, Madison, the work that she's doing at Options is kind of the solution to a lot of these problems that we're highlighting. But one thing that really stands out is just the importance of ongoing support in housing first. So once you get them into housing, making sure that they are, accessing services, that they do have, opportunities to participate in their communities and make those connections. Being housed after being homeless can lead to social isolation because a lot of people are separated from the social networks or communities that they were before. And so it can be super isolating, being alone. Like the topic of feeling alone in housing has come through in the analyses that I've done, but across other work that we've done in Housing First. So I think in terms of what we could do is really support people to reconnect with family members, reconnect or find new friendships, new positive relationships, participate in community programs, community development programs, things like social prescribing to really get them. I think that's so important for housing stability. The other aspect is just addressing drug use and harm reduction approaches to improving substance use in Housing First programs, because that still seems to be a very big barrier to social capital, and that's backed up in the limited literature on social capital among homeless people. Drug use is a pretty big barrier. And then finally, supports for Indigenous populations that obviously face challenges accessing social capital due to their history of colonization and displacement. So that's it. I don't know how long that was.
So thank you, Ada. And we'll move now to our final presentation by Matt Larson. And Matt is pursuing a Master's of Science in Community Health Sciences at the University of Calgary. And he's going to talk with us today about We Can Persist, exploring the phenomena of stigma and shame as experienced by people with lived experience of homelessness and diabetes through the lens of shame resilience theory. Matt?
How do I get it to presenter mode? Bottom right. Oh, thank you. I have a different version. There you go. Yeah. Yeah. So as I was introduced, this is the name of my project, exploring the phenomena of stigma and shame as experienced by people with lived experience of homelessness and diabetes through the lens of shame resilience theory. Yeah, just a quicker title though is We Can Persist. I think that just comes off pretty quickly. And persistence really means a lot to me in my own journey. Oops, skipped over. So in my journey, I have personal lived experience of homelessness, addiction, and mental health issues. Currently, right now, I'm a graduate student in the second year of my Master's of Science program at the University of Calgary. But yeah, this is my past. The picture on the left here is one of the shelter, the cells of the shelter I was staying at called the George Street Respite. This was in downtown Toronto, and across the street from Seton House, which is another kind of notorious shelter in Toronto. And The George Street Respite was actually a former juvenile detention center. So basically, we're staying in jail cells in there, and that actually was one of the better cells. Eventually, at the end, when I had to come back again and live in the George Street Respite, I was like, they were at capacity, so I was. They put me like in the kind of one of the hallways where the light's always on. You have to sleep under the burning light all night. Not very pleasant. So yeah, so that's just to give you a little bit of background about myself. I was homeless from May 2018 to about August 2019. Yeah, I just took this picture. Maybe it's weird that I took this picture. It's like I took it because I didn't want to forget, right? Like I knew I wasn't going to be homeless forever. And well, I hoped at the time that I wouldn't be homeless forever, and I just never wanted to forget it, where I was. Like I mentioned, I have a history of mental health challenges. I was hospitalized for mental health emergencies about 3 times between 2016 and 2018. I've been stable about since early 2019. I have bipolar and depression, clinical depression. And yeah, I've been pretty stable again since 2019, basically since I started taking my meds regular. I started taking my meds like I was forced to when I was in rehab. Yeah, it's like they make sure that you're taking your meds 3 times a day or you get like a strike on your record. So I think that actually helped. Like it helped, like I was really militant about taking my meds. Yeah, and like I said, I did drug rehabilitation from September 2018 to about January 2019 at Harbor Light Ministries in Toronto. Again, it's run by the Salvation Army. The picture on the right is actually, it's not Harbor Light, it's another homeless shelter I was staying at, the Maxwell Meagan in downtown Toronto. Yeah, that's just to give you a little back history of myself. So when I got out of rehab, I went to a sober living house in Toronto, and this was the poster that I saw in one of the common rooms of the house, basically advertising a study about diabetes and homelessness. And at the time, I had just started like in the house. Apparently, you had to get a job, is what they told us, or you had to either get a job or like do school or something. So I asked the guy running the house if I could instead do this study, and he said sure. And that was great because it was also compensated, which was really nice. It says that in the study, so I was pretty excited. Basically, a job. Yeah, so thus begins my work with the Toronto Clients with Diabetes Action Committee, the TCDAC. So this was back in, again, early 2019 is when it started. And group meetings took place in Toronto and ran from December 2018 to June 2019. The group was facilitated by Dr. Dave Campbell, back there. And yeah, it was facilitated by him and Rachel Campbell. Excuse me one sec. Yeah, all the community members at the time, there were about 7. All the community members, like myself, had lived experience of homelessness and diabetes. And this kind of, the research group is called community-based participatory research. Basically, just there's a lot I could say about it. Basically, the fact is just community co-researcher, like the community members with lived experience work with academic researchers, and the partnership is like about sharing power. I think that's the main thing. It's about sharing like power and autonomy over kind of how the research is done, what is researched, et cetera. And one of the things that we did in our group, the top picture is like the sorting activity that we did. It's like I believe it's like we polled not only people in the group about like what were their concerns about diabetes and homelessness, but also other healthcare professionals about what were their concerns. And within the group, we did a sorting activity and basically decided which were the top priorities that our group wanted to look at and research and learn more about. And it turns out the main priority for that group was about finding like healthy food for individuals with experience of homelessness and diabetes, because that's a major problem, right? As anybody who's been in a shelter, well, I don't know how the shelters where you guys have been in, if anyone has been in one, but shelters that I was staying at, even the rehab center, right? Like it's all food that's been donated, right? Or shelf-stable stuff, like a lot of rice, a lot of stuff like that, potatoes maybe. So it's not the best for diabetics. Yeah, so the group culminated in multiple photo exhibits. To back up a bit, after we had kind of done the research, what we decided to do to get the word out was use a process called photo voice. And what that is there's an example of it on the bottom right. This is a picture that I took. And it's like we you take a picture and then basically underneath you kind of explain about what's happening in the picture and how it relates to diabetes and homelessness. And yeah, this was just the picture I took. And on the upper right-hand corner, you see that's from an exhibit that we did. We did several exhibits. I think that one is in a hospital, yeah, St. Joseph's, I think, yeah. Anyways, so yeah, we did got tons of views. Yeah, there were several articles written about the photo voice exhibits and the process of our group. And participants gave talks at conferences and to academics and media outlets. And also, yeah, we were at the 2019 Canadian Alliance to End Homelessness in Edmonton. I don't know if anyone was there, but if you were there, you would have seen these photos that were lining the halls. Yeah, since working with the CDAC, I've had a few other publications. I wrote Home Sweet Homeless, basically in honor of the work that we did in the Toronto CDAC, and just explaining some of my own journey and also the work with the Toronto CDAC. And yeah, the other one is just an article that was written about me when I joined the University of Calgary. Yeah, so now, currently, actually, sorry, again, after working with the Toronto CDAC, we started a new participatory group back in April of 2021. That group is currently running. We have some members here and back in the back there. This is called just the CDAC, the Calgary Diabetes Advocacy Committee. So not to be confused with the TCDAC. But again, similar thing, community-based participatory research. Again, all co-researchers have lived experience of homelessness and diabetes. And first of all, the group, again, because it was in April 2021, back when COVID, lockdown was happening, the group started virtually online, with basically just members meeting to discuss issues that they had with their diabetes and homelessness. And basically, again, similar to the TCDAC, it was like we're trying to figure out what should be the focus of our research for this group. So as of today, as of now, the group has completed several research projects. In addition to a short film, Low, which is presented there. Hopefully you guys are all invited to come and see it. It's at the end of the day today. And it's good. It's like a legit movie. It's not like, somebody with a camcorder just watching it. And it's really, anyways, it's you guys should check it out. Yeah, so moving on to my project. So my project, again, it makes sense, I guess, because I've kind of worked in research related to homelessness and diabetes for so long. I wanted to kind of continue with that topic. But another topic that really interests me is the topic of shame. Shame is very prominent kind of feeling in my own journey. And I dare say that might be the same for other people with lived experience of homelessness. So I'm really just wanting to go kind of deeper into understanding that emotion and basically how to become resilient towards it, because I think it can be very debilitating. But just to speak about my project, if you don't know anything about diabetes, really briefly, high blood sugar and low blood sugar are bad, right? That's the thing, and diabetes makes it hard to control. And you can have really bad outcomes from being too high or too low. You can die. Right, so it's very important to keep your blood sugar steady when you're diabetic, but it's also extremely hard. Right, again, you'd see that in the movie that we're showing later today, but it's again, you don't have control over what you're eating. You don't have control of when you're eating. Right, you're crushed by depression. Right, at least I was. to the point of immobility. Right, you can't you're supposed to exercise. You're supposed to take care of yourself when you're in that situation, and it's very hard when you're emotionally damaged, right? And another thing too is the stigma, right? The stigma. So again, this is an emotional blow. The stigma not only of homelessness, but even diabetes, right? I think type 2 diabetics, I would say, experience more stigma, but it's again, people don't know sometimes what's the difference between type 1, type 2, right? So it's there's an individual in our group with type 1 diabetes, and she says that she also experiences stigma as well, right? So it doesn't really discriminate. Yeah, but again, of course, and everyone knows there's obviously stigma towards people with lived experience of homelessness. yeah, and thinking about this, these negative feelings can inhibit one's motivation to engage in self-care. That's what I was talking about. You know, it's like you feel depressed. I mean, the last thing you want to do is like go for a run, right? Like, you know, go work out or something. Even though that's like the best thing they say is like you should be doing stuff like that. It's like, yeah, exercise is better than like mood stabilizers. But yeah, I think that's the last thing people want to do. So yeah, even though like shame is endemic to this population, some people do all right, right? Some people can cope adaptively. They can exhibit resilience and effectively manage their chronic illness and social complexity, right? This is evident. Some people do better than others, right? The focus of my project is basically trying to understand why. Like, what are the determinants that lead to better outcomes for this population? So my idea is that they have something to do with maybe shame resilience, again. So just briefly going through the study objective. So we want to explore the experience of people with lived experience of homelessness and diabetes, again, with a focus on understanding the phenomena of stigma and shame. The research question, what is the perceived impact of certain coping strategies on a person with lived experience of homelessness and diabetes, ability to be resilient towards stigma and shame? Okay, so a really giant word, hermeneutic phenomenology. It's phenomenology is the study. This is the study of lived experience. Is basically all it means. Yeah, it's very complicated to kind of go into, but just the briefest definition, phenomenology is just the study of lived experience, and hermeneutic phenomenology especially involves interpretation of the essential meaning of the phenomena. Right? So the idea behind my project, again, it hasn't started yet, but the idea behind my project is to basically appeal to the co-researchers, the CDAC co-researchers that we're working with, and my own experience to kind of interpret the understanding of lived experience of the other people that we're going to be interviewing. So we can understand more their feelings of, their experience of stigma and shame. So yeah, I think this hermeneutic phenomenology is a really good method, right? Like being able to refer to my own kind of experiences is going to help, I think, in the analysis process, right? Getting to know the what it's like for the other people who have been through similar things. So just briefly, what is stigma, guilt, and shame? These are like the main terms that we're dealing with, so I want to define them. Really quickly, stigma is a socially determined flaw. Basically, like think of it like a stereotype. And like a stigma is kind of like a stereotype that has got traction in society, right? And I think it's like common, right? You kind of hear it a lot. So again, like it's like the stigma behind homelessness is quite clear. Guilt is defined as a feeling that results from acting in a perceived flawed or bad way. Something like this, it's just I want to differentiate it from shame, but an example of guilt might be something like, I feel bad that I got addicted to gambling, lost all my money and became homeless, right? That's like, you feel bad because you've done something. Shame, however, is different. Shame is a feeling that comes from self-attributing or believing others attribute to us characteristics that undermine our self-ideals. So basically, it's like when you hear people say that you're low class or something because you're homeless, and it's like you gradually kind of believe it, or you come to understand that like yes, that label does apply to me, and this leads to the belief that we are flawed and therefore unworthy of acceptance. Basically, that's the essential characteristic of shame. I would say is like an inherent feeling of unworthiness. Yeah. So how do we cope with stuff like this? Just the definition of coping first. Sorry, I couldn't think of a better picture other than this Homer picture. Like to kind of it doesn't really fit with the mood of my program, but I don't know, it's there. So the coping is defined as the conscious or voluntary efforts used to regulate or manage one's emotions, thoughts, behaviors, and physiological reactions in response to stress. So really, like traditionally, coping is thought of as like adaptive and maladaptive, right? In the top picture, we have an example of like adaptive coping, right? In the situation, this person's reaching out, asking for help, right, and receiving it. And yeah, some people can do that, right? Some people can like appeal to others to get help, right? Again, some people can go the other way and just isolate, right? And the bottom, with Homer, we have the example of maladaptive coping, right? So it's like he's just basically not dealing with the problem, right? Like it's a problem for him down the line, right? So I think that's a good example, kind of like procrastination. Procrastination is another good example, kind of maladaptive coping, I would say. What is resilience? Yeah, the capacity, this is the long definition, the capacity of a dynamic system to adapt successfully through multi-system processes to challenges that threaten system function, survival, or development. Basically, I think just a really quicker way of saying that is like being able to persist through adversity, something like that. I think that's clearly the case, like being able to do well despite bad stuff happening. I think that's another way to think of it. So yeah, obviously we can think about when people are dealing with homelessness and diabetes, like the situation can like being able to overcome that situation can make people stronger, but it can also, like if people aren't able to overcome it, right, it can kind of like hurt them more and make recovery like harder. So again, my study is kind of based on like why do certain people do better, right, than others, and I think it has to do with like basically their capacity for resilience, and I want to learn more about that. So what I did was I was looking at shame resilience theory. Excuse me. This is a theory espoused by Dr. Brene Brown back in 2006. Dr. Brown, she interviewed 215 women from diverse backgrounds across the country, and basically she was asking them about kind of how does shame take root, like what are the causes of shame for these women, and basically she said that shame is the intricate weaving of the following three emotions, and feeling trapped, feeling powerless, and feeling isolated. And I think just those terms like trapped, powerless, and isolated, I think you can see how those apply to people with lived experience as well, right? So it's like I think again, people with lived experience are intimately familiar with this. So again, this is for my project. The idea is to just how are we going to get this data? The idea is to basically recruit 5 to 7 individuals with lived experience of homelessness and diabetes, recruit them from the community. Again, this is happening in Calgary. So we're going to put up flyers in homeless shelters and recovery operations, and hopefully get some people. Participants will complete 3 separate semi-structured interviews over 3 months. These interviews will focus on shame and stigma related to diabetes, shame and stigma related to homelessness, and coping with shame/shame resilience. And the idea is, again, we're working with CDAC members who have worked with us for a long time now. And hopefully a CDAC member will sit in on the interviews, ask additional probing questions, take field notes, and debrief with me afterwards. So yeah, we want to keep them involved all throughout. Yeah, and again, that includes the data analysis section as well. We're going to get CDAC members to do the line-by-line coding with myself, basically assigning like themes, thematic analysis, step by step. They're going to receive training as we go, and guidance through the other academic researchers in the project. And like I said, yeah, using hermeneutic phenomenology, it's like the analysis is going to be aided by our past experiences, right? So we're going to, basically try and think about where we've been to kind of better understand where the participants in the study are currently. And rigor will be maintained by discussing our interpretations with the group, conducting member checking with interviewees, and performing regular reflexivity activities. I think reflexivity is key in this study, especially because it's like people with lived experience of homelessness interviewing other people with lived experience of homelessness. And I imagine there's kind of a lot of challenges to reflexivity and like not projecting your own experiences onto somebody else in the situation. Sorry, I hope I'm not going over time. Okay. Yeah, so because I'm almost done. Potential benefits of this study. Yeah, the participatory nature of this study will yield novel and rich insights into the lived experience of people with lived experience of homelessness and diabetes. Yeah, I think this study is pretty novel, right? Like really utilizing the experience of this population in quite a deep way, and kind of getting their help from the start. And again, the kind of idea behind this project kind of came from my interaction with other members, right, and my own experiences of homelessness and diabetes. So I think it's kind of rooted in that, in like the community, like real members of the community. So I think it does kind of focus on issues that are relevant to this population. Increased understanding of the experiences of stigma and shame can help those in the homeless serving sectors engage more fruitfully with this population. Yeah, I think it's like this can be, educational for homeless shelter workers, and maybe learning how to be more sensitive to the needs of their clients. And I think kind of learning about this experience of shame could really do that, could really sensitize them. And lastly, teaching elements of shame resilience theory to people with lived experience of homelessness and diabetes, and those involved with helping them may lead to more effective coping and resilience. So that's the basic idea. Yeah, I didn't explain about it much, but the idea behind shame resilience theory is becoming resilient towards shame, right? Learning to basically not feel as shamed about your experiences. And so hopefully, throughout the study, not only the participants, the interviewees, will learn about that, but also the CDAC members as well. Yeah, and that's it. Thank you very much. I just want to thank the CAEH and the Paula Goering Scholarship for bringing me here, and Dr. Dave Campbell, my friend and mentor, and for everything. Thanks.
I want to thank Matt for his presentation, and also just for sharing so much of your story and yourself, Matt. It's just a really great example of engaged scholarship that it just feels very whole. So thank you. I was going to ask you too, before we open it up for questions, there's the movie that's going to be shown, right, Matt? So, what time is that, and do you know where it is,
5:15 in 501, I believe.
5:15 in the ballroom.
In the ballroom.
Okay,
Yeah.
great.
Ballroom level 501. Sorry.
Okay,
Yeah.
super. Thank you.
It's in the program too. You can double check on the program.
Okay. Okay, so we have time. We're going to open it up for a question and answer period. So if you want to, I don't know if we have a microphone out here, but we have a maybe we do, but we have a small room too. So I think it's okay if you just want to pose your question and indicate who the question is for, or if it's for more than one person, please feel free. Yes, go ahead. You got a mic coming, so there you go.
Thank you all for sharing your work with us today. My question is for Matt. I have two questions. First, how do we follow the results of your research? Where can we find that? And then, I know you said it's in the coming months. And then my second question is I'm just curious to learn about how you teach folks about the shame resilience theory. Is that like a form of therapy, or what does that look like?
Yeah, to your to your first question about where can you follow the results. The idea is at the end of the study is to basically write a paper and to have the co-researchers contribute to that in some way. How it is, again, it's still happening. I'm still trying to parse out all the details, but I'm thinking of the co-researchers can kind of choose how they'd like to add to the paper in a way that kind of suits their communication style. Some people might want to write, other people might want to draw. I don't know, something, but we discuss it with them, and that'll be hopefully published. And also, I think we're going to be sharing our results with community members, like other shelters and whatnot, and probably CAEH again, right? So that would be probably a good place to check it out, hopefully, if it gets there. But to your second question about how to teach shame resilience theory, I think Brené Brown mentions psychoeducational groups, which is basically groups of people with lived experience, stuff like grief, like groups for grief or something like that, people who have experienced grief talk about their grief in a group like that. I think it would be the same thing. People with considerable shame would kind of share about their experiences and maybe receive tips on the shame resilience principles from a moderator there. But I guess in that case, it'll be me kind of teaching the group members, and I have to learn about it first. But or learn how to. I mean, I get like a basic idea of shame resilience theory, but I want to like more detailed to be able to learn how to teach it. And it's good though because like one of the main principles of shame resilience is empathy, and we've really established that with the CDAC group that we have 100%. Like we've really like understand each other's situations now from working together for so long, and really have a lot of respect and trust for each other in the group. So I think, you know, like being able to like open with our emotions and being able to talk about this sensitive issue, I think is going to be pretty easy for us. But yeah, that's the idea. Yes, yeah, exactly. Thanks for the question.
Other questions?
Yeah, go.
Yeah, please.
I got a question for the young man. And that, with your studies that you're doing on your research right now, are you coming up with any blueprint plan to take action? Something we can go by to make change? Do you have anything in the works, maybe?
Should I get the mic?
Sorry.
It's a good question. Thanks, stranger that I've never met before. No, that's a good question. And you bring up a good point. Like community-based participatory research, it's also known as like community-based participatory action research. And the idea is to put these like the results into practice that we do. And our group is traditionally known for being good at that, right? Like we kind of make change and get the word out about what we've been doing. And right now, yeah, I don't know. I'm not exactly sure about the action step that we're going to take. I mean, it would be nice to kind of get this information, like I said, into the hands of shelter workers, so maybe they can be more understanding of the situation of their clients. But as for tangible action steps, I'm not really sure, to be honest. And again, maybe I can appeal to the co-researchers in the group to give me ideas, right, as we go. Because again, that's part of it, just trying to figure it out as we go. Maybe you guys have suggestions down the line. Yeah. Thanks.
Thank you. Some other questions? Yes, please.
I have a question about the peer facilitators and peer navigators. Is that a full-time paid position in your organization, or how do you staff it? How do you keep it staffed? I know there's a fair bit of turnover and people moving maybe out of Ottawa or to other locations. So what's your process for kind of keeping those roles filled and trained and all that kind of stuff?
Yeah, so on the Housing First team, we have 2 peer workers. They're part-time. I think they're 20 hours each. I'm looking at my manager and my ED for confirmation. And then we also have a PACE program that is linked up to our hoarding assistance program. I believe they're part-time as well, right? Yes. So yeah, they're currently part-time, but the need is definitely there for a full-time position, absolutely. I know, I think we definitely have well over 100 clients on our team, and I know the peers are definitely, they're loaded up, so there's definitely space for more peers in the future, and I know that's some of the options that we're really building on and aspiring to do more peer work because it's really made a difference in the Ottawa community.
And how do you train them? What's the process for getting them kind of up to speed to become a peer worker?
Do you want to jump in, Catherine?
No, just on the pay part,
Yeah,
that's
yeah.
the important piece,
Sure.
because peers are not always paid on
Yeah.
par. So our peers are all paid at the same rate as our housing support workers.
Oh, amazing.
So they're paid on par in all of our programs.
Fantastic. Thank you.
Go ahead.
Sorry, what was the second part of it?
Training, and what's the process like for somebody to become a peer worker?
Yeah, so I know we really value lived experience. So for the training, I'm not 100% sure because I haven't been involved with it. But I know there's a lot of opportunity internally for training. I know the peers have the same opportunities as housing-based caseworkers to go to trainings. In Ottawa, we have free trainings put on by the City of Ottawa. They're virtually right now, but the peers have access to that. So motivational interviewing, assist, all those kinds of things that are really vital to help clients. So we really try to make an environment where, you know, we're on an equal playing field and the peers have equal access to us because at the end of the day, we're both, you know, supporting clients and we both need to be equipped, you know, the best that we can.
Some other questions?
Now, I'm really interested in the isolation piece you mentioned in Ada, right? In your project. How do you, because isolation is like, I think, one of the most pernicious things about shame. And I'm just wondering, like, did the results of your project kind of speak to how to minimize that, or what are your suggestions? Maybe for, I don't know, for this community that's really stigmatized.
So actually, one of the things that I do code for in my analysis is the experiences of stigma and discrimination and social exclusion and how that relates as a barrier to social capital. And one thing I didn't get to talk about is there's a concept of negative social capital in the literature itself, which can be looked at as a lack of social capital, but it also talks about how certain types of relationships might be harmful to certain people or have negative outcomes. And so for me, it was just interesting to see how many participants talked about that self-isolation piece of wanting to keeping their distance from others was a phrase that came up a lot. And then just the topic of shame, like how they wanted to dissociate with how they viewed other people within the same circumstances that they came from. So even the quote that I used of like wanting to separate themselves. So it seems like that feeling of shame was also there, and wanting to kind of step away from that or say that, no, I'm not like that, which is so, honestly, it's kind of sad to kind of see that coming through as a theme. In terms of what I think is the main, way to address this is through access to more social support through community programs and community resources, but really this piece of getting people to participate where they live. So community development programs, peer support, obviously, speaking to people with lived experience and how they've gone out. That piece about resilience is just huge in terms of having people within your social network that have made it out, and being able to kind of learn from that and follow those steps. So I think just kind of creating an inclusive and positive environment where people can, not fall back into this feeling of social isolation, into depression, hiding from others in their units when they're housed, and realizing that coming out of homelessness means that you lose a lot of your social network, a lot of the people that you used to know, and how there's some grief there as well too, because these are people that you've had a intense experience with, and then trying to move away from that. There's a lot of themes that came out, and especially the qualitative. I end up talking about the qualitative stuff way more because it's just so much more interesting than the boring theoretical models and stuff like that. But the thing that kind of came out of like missing, like they're in their housing, but they miss their old community. They miss their friends, on the streets, or there was a couple who lived in parks. So yeah, I think that was a long answer.
Yeah, go ahead.
Question of Ida.
Yeah.
I'll ask about your boring models. I'm interested in, did you use path analysis or structural equation modeling, and why did you choose that particular approach to your modeling?
So I did, so path analysis is technically a form of structural equation modeling. I use SPSS Amos to kind of conduct my analysis. I don't know if that answers your question. And then I didn't really describe like how social support and psychological integration was measured, but they're validated scales that have been, utilized throughout homelessness research for a while.
So all your variables were defined. You didn't use a latent variable?
No, everything was defined. Yeah, so yeah, that's one thing that makes it structural equation modeling is that, yeah, it was just regressions. It's just a series of regressions.
That gentleman, he could be your external examiner, that's one of those kind of questions, isn't it,
thesis topic, so you guys are prepping me.
You did pretty well on that one. I'm just wondering if maybe you'll comment on this. When Putnam wrote his book, one of the things he found was social capital's diminished over time. Right? There's a linear trend. We have lower levels of social capital than we have 40, 50 years ago, and it just keeps going down. And then there was a pandemic.
Yeah.
And I just wonder what challenges that makes, for, trying to help people get reintegrated, build that capital, have those support groups and have them talk about, these issues, like the people that are homeless, around their diabetes and shame and all of that. Are there strategies or ways that you can see, like, to deal with it? Is this a challenge, I guess, and then what do you do with it?
Good question.
Yeah. Well, that's one I wonder about a lot.
I know with our clients, definitely post-COVID, the social isolation has been, immense, especially with, like a concrete example, like folks who were planning to go to treatment and then all of a sudden, lockdown and they're unable to access those resources, so they fall deeper into addiction and, even now we're coming out the other side of COVID, but those resources maybe don't exist anymore. So we're finding a large gap with that, trying to get people out of their apartments. After 2 years of being told they have to isolate, now trying to get them back into the community has been really difficult.
Tough.
It's tough, yeah. It's really tough.
I might add, so I think it's interesting because the types of social capital are pretty important. And when it comes to that last piece of linking social capital, everyone here who's part of this conference can play an active role in improving that. So, improving relationships and experiences that this population faces in the court system, in community services, with their experiences of police, addressing police discrimination, and how these experiences really create this sense of distrust in the institutions that you're also reliant on, you can't survive with, because that's another thing is that these community service organizations are often the only source of support that some people from these communities have because they're isolated from their families, from their friends. And so I think that piece, not only being conscious of it, just being actively aware and really from intervention points of view, trying to address these issues to at least get that linking piece. And if you feel like you're in a country or society or a community that supports you, that fosters into greater trust in your neighbors and other citizens that you meet on the streets. Like it's all of these kind of tie together and overlap. So I think that's one place where we can kind of improve.
The question was how to increase social capital?
Yeah, in this kind of challenging context where it seems to be diminishing.
Yeah, I think,
Yeah, I think if I was I think of examples like this, like how to establish more connections, more relationships with people. Like CAEH is great, right? It's like a place where people with lived experience, don't feel like outsiders. I think here's a good place where I don't feel like an outsider, right? Like I work in academia and I also work with people with lived experience, and it's kind of like it's hard for me to feel like I belong in either group sometimes. Like I want to be an insider with both, but it's a difficult line to walk. And I don't know, at this place it feels more normal, right? Like it feels like individuals with similar experience to myself are starting to do more like work like this. And that's important. It's important to just be able to see that. And like I said, the normalization, like we have the lived experience lounge downstairs, which is great. Like people with lived experience can just chill there and just talk to other people. And it's just like, a space for us, which is good. And I think that's important to kind of respect, to respect like those boundaries of those individuals. So like we can like give them their space. And I don't know, I think about other groups too, like how to form like healthy relationships. Like I've been in 12-step groups over the years, and I think those are really, really important. Like people trying to get clean and trying to do a program to help themselves, and you can form new relationships through them. But I think it was mentioned that there is definitely a sense of loss, right? Like of kind of leaving your old life behind, and I don't know. I'm not sure really how one mitigates that. I sometimes feel that myself, right? Like I miss my friends from when I was using drugs and all crazy and stuff. I mean, there are some good feelings, like some good memories I have with that too. But it's like it's not worth it to go back there, right? I don't know.
Yeah.
Actually, AA
Is it-
came up a lot.
Yeah.
Yeah, it's a theme.
It's a transition. It's really a tough transition, yeah. Okay, are there other questions? Yeah, please.
I just have for Ida.
Yeah.
This is a little bit off topic, but maybe you can comment on that anyway. You talked about how people really don't trust like the courts or the police or the government. Is that because of like negative experiences? Oh, thank you. Or do you think that's maybe because like they've experienced this trauma, so they just don't have like trust in anyone? And if that's the case, like, do you think it would make it a lot harder to house those people who just don't trust anyone or like anything because of that trauma?
Yeah, so it is what I'm actively coding for is negative experiences and descriptions and interactions. It was so this is secondary data analysis. So I didn't interview. I was involved in the interviews with the HIT study, but I didn't ask these questions directly to the participants. This was kind of secondary years later, and I was looking at themes. And so how I was coding them and the thematic analysis is looking for descriptions of negative experiences. And it was interesting to me that they just directly would state, like, I don't trust the cops, or I don't trust the doctors. And a lot of that was just lack of being listened to. And then on the other end of that was, when they described things positively, it was feeling that they were heard and feeling that the person that was helping them really understood and was active. And another thing that kind of came up in terms of the linking piece was a lot of participants not being aware that there's actually people out there that want to help them. So that statement has been coming up of like, I just didn't know that there's people out there who care and want to help me. And so that one relationship with whatever service provider or case manager or some shelter worker who really like had a huge impact in these people's life of thinking, yeah, there are people that care about me. So that touches on the social support piece and the sense of belonging piece. So it was based on negative experiences, and then just those, spot on quotes of I don't trust, or I'm learning to trust is another one that came up from some participants where they previously had this sense of distrust, but now that they've gotten housing and they've had people who have helped them, they're learning to kind of change their point of view and focusing on the good qualities of people. So there's really, a theme of seeing people wanting to improve, and it was interesting that the golden rule would come up of treat others as though you want to be treated. So these kinds of themes were coming up. So I did see opportunities for people to kind of develop that trust in institutions, and that's based on having good experiences with them. Okay, I think that's it.
Kind of reminds me of, I visited, the original Pathways program in New York City. I went down there and visited years ago. And there was a woman who had her own apartment, and she had previously lived for, 15, 20 years in one of the tunnels going into Grand Central Station. The Housing First workers kept seeing her and saying, come on, we'll show you an apartment. What's this apartment? So they eventually showed her an apartment. They got her in an apartment. Everything was tickety-boo. And then they found out she didn't stay in the apartment. She went back to the tunnels because that's where she knew everyone. That's where she was comfortable. And I figured, So the case managers, they took her around the neighborhood in the apartment block that she worked in, the grocer who was downstairs, and she gradually met people. And she started sleeping in her apartment. So, had to look at that transition for people, and help them navigate it, make the new connections. If there are no further questions, I want to just thank the three presenters for their excellent presentations and acknowledge their work that gave them the Paula Goering Award Scholarship. So thank you all. And